I'm Samantha Lau. Welcome to Behavioral Health Radio, your resource for all things behavioral health. Each episode features open conversations with experts from every field in the mental health care industry. What does it mean to deliver world-class mental health care? This really matters. So, let's talk about it.
Hello viewers, thanks for tuning in. Today we have Dr. Charles Rich, MD, Professor Emeritus of Psychiatry at the University of South Alabama. Dr. Rich has collaborated with international scholars in suicide prevention research. He has also served as an expert in many civil liability cases involving suicide. We're going to be discussing the history of black box warning on antidepressants and its impact on mental health care delivery. Warm welcome to you, Dr. Rich.
Great to see you. Great to see you. Thanks for having me.
Thank you for being here. So kind of you. Can you please educate us about the history of the FDA black box warning on antidepressants? Well, you can define it.
Right. First of all, the black box is a method that the FDA uses to call attention to what they call serious or life-threatening risks of the products that they approve for use. And it involves printing a black line box around the designated warning in the product information that's actually given to physicians and patients. And this is I don't know if you can how well you can see this, but
Okay.
there's you see the black box around this. I mean, that's just an
Right.
example of what it looks like when
Yes.
it's given to you or given to me as a physician and so forth. Now the question is, what does life-threatening and serious mean? And I think we all kind of have a fairly good idea about what life-threatening means, but serious is a different matter, and that's where there's some discussion about the use of the black box. If you were to ask what the definition of serious is, you probably wouldn't get one. It's kind of, I don't know if you're familiar with this situation where it's sort of like, if I see it, I know it.
Yeah.
You know, but I can't define it. I just know it because I see it there, and that's kind of what serious is meant, and that's kind of what's caused some of the problems.
Mm-hmm. But how do you differentiate that with adverse reactions?
It's an extension. It's an extension of that. I mean, it is a way of pointing out adverse reactions that people should be probably more aware of being a possibility of causing harm. You know, anytime you put anything in your system, whether it's a medication or a health food substance or your cereal in the morning, there's a chance you might have some kind of adverse reaction, which wouldn't be serious or life-threatening. And so a lot of those get listed with drugs as well, but when they put a black box around it, it's a way of calling attention to everybody that this is of greater consequence.
What are the legal complications of such a warning?
Well, some people have been misled to believe that the black box around these things actually prohibits physicians from prescribing the drug under certain circumstances, which isn't the case. It simply warns people that if you do that, you must exercise greater caution. Now, the other side of that coin is, though, the liability issue, and there are many physicians I know, for example, who worry that if they prescribe a drug like with a black box around it to somebody who's warned about and something goes wrong, they might be liable for lawsuit at a greater extent. Now, whether that's actually proven to be true or not over the years, I don't know, but it certainly is something in the mind of many physicians.
Do you know how many FDA-approved medications with?
Well, the last time I checked the internet, the number I saw was like 750.
That's a lot.
Well, it is, but it's not as many as you might think, because what happens is that if you have a warning on a particular drug in a class, let's say an opioid, for example, for pain killing, that means that the warning has to go on every opioid in that class, of which there are many, as you're probably aware. And it has to go on all the different products that may contain an opioid. So for any one drug, there might be 10 or 15 or so products that actually have that substance in it. And that's what makes the number go up. Now, for example, in 2016, there was a warning placed out warning people about combining opioid drugs with benzodiazepine anti-anxiety drugs as being particularly risky. Well, that included about 400 different products that had one or the other or both of them in it. And so the number kind of escalates when that happens.
And when did the concern about antidepressants and suicide come to light?
It was around 2003. The British Medical Council issued a warning to its physicians about an antidepressant called venlafaxine, which they had determined by virtue of whatever studies they did might have an increased risk of suicide and suicidal behavior associated with it. That sort of theme was picked up by the FDA, the Food and Drug Administration, in 2003 as well. But they applied it to another antidepressant called paroxetine in this country. And there was thought again that there was associated possibly with a greater risk of suicidal behavior.
So it's not Prozac, it's Paxil.
No, that was not it was called Paxil. That was
Right.
The brand name was Paxil.
Right. I thought fluoxetine was the first one.
Yeah, fluoxetine was the first one that was introduced in this country, and that was in 1986. Paroxetine came along later, and the problem with paroxetine was that that it got caught in another kind of sort of scandal that people were noticing between the Food and Drug Administration and the pharmaceutical industry. There was at that time a pain medicine called, if I can pronounce this right, rofecoxib, and the brand name was called Vioxx. I don't know if you remember that one or not, but it became known around 2003 or so that there was apparently some attempt to not provide information to the public about a risk with rofecoxib of heart attacks. And there were some allegations of collusion between the FDA and the pharmaceutical company, but I don't know where that ever ended up. They ever proved anything, but it certainly put everything on edge, and so there became a heightened awareness at that time. Well, at that time also, for some reason, the people who had done the clinical trials with paroxetine were thought to have not reported adequately the side effect of occurring suicidal thoughts and behavior when they reported their information to the Food and Drug Administration. And so the Food and Drug Administration initially in 2003 issued a statement, a public statement, advising people to be aware of this possibility. But it wasn't until 2004 that they actually put the black box on the antidepressant. Okay. That was in October of 2004, so it was almost a year later. It was also about that time that Vioxx, the pain medicine, was actually withdrawn from the market.
Okay, so we were talking about that was the case for paroxetine. Then why did FDA put a black box warning on all antidepressants?
Well, as I mentioned earlier, it's a guilt by association phenomenon. And this got actually, it was a different sort of situation. If you've got one opioid and you're warning about it, all opioids are pretty much the same. But interestingly, not all antidepressants were the same. But for some reason, they felt like they should put the warning on anything that was called an antidepressant. Right. And so it included many drugs that have never actually had that kind of research done on them to actually see whether that happened or not. But they got caught up in this guilt by association phenomenon.
And what did the warning say?
Well, the warning talked about increased risks of what was called suicidality in children, adolescents, and young adults, but not in, I guess, what we might be called, or certainly I would be called. It wouldn't apply to me. It might apply to you, but it wouldn't apply to me.
That's all based on research, correct?
Sorry?
That's all based on research.
This was based on. Okay, let me back up. When a company wants to introduce a drug for use to the public, it has to supply research information to the Food and Drug Administration, proving its safety. Mostly, its safety,
And
efficacy too, but mostly safety. So that's where this information comes from. Is all the centers that are doing the research give the information to the Food and Drug Administration. They analyze the data and they come out with this issue. Now, so the question is, what is the relationship between suicidality, which is what they were talking about, and suicide itself? And this is a tricky concept because there's a lot of overlap. You can imagine, for example, that everyone who commits suicide has had suicidal thoughts and behavior. I mean, it just has to be 100% of the time. However, when you look at all of the people who have ever in their lifetime had any thought of suicide or maybe some act of self-harm, the vast majority of those people never die of suicide. So there's a lot of confusion in the public about the use of those terms. And most people don't really understand the distinction, and they are often used without distinction in the public.
People are often very scared of starting an antidepressant because of the black box warning. They think that when I take this, I'm going to have suicidal thoughts and I'll commit suicide.
Yeah, that's one of the possible conclusions that we can get to in a bit.
Right. What other problems do you see with this black box warning on antidepressants?
Yeah. Well, the first problem was that I think is really caused consternation among providers is that the wording of the warning said antidepressants increased the risk compared to placebo, which means to say that in a group of people taking antidepressants versus people who were taking dummy medication, the warning said that the antidepressants increased the risk of this suicidality. Now, that's not really technically a correct way to make the statement. The statement should be an increased risk was found, but the reason is unknown. The implication of saying that it increased the risk is that the drug actually caused the risk to go up. And there's no evidence that that's the case. We knew that it was a little higher, but we don't know if that's really what made it go up or not. So that was the problem that it caused. And you even see carryover of that kind of difficulty with language in the advertisements you see on television today, where you see where people say drug X or something has been shown to cause suicidality. But there's no evidence that it causes anything. It's just an association. Now, if you look again at that data, for example, that the FDA had where they drew this conclusion, another researcher, Dr. Arif Khan, and his colleagues looked at the same data from the same studies and looked at suicides in that data, and they found no increased risk for actual suicide between the active drugs and the placebo drugs. So the fact is there's never been any evidence linking antidepressant use with increases in suicides. And in fact, there have been studies that began with a landmark paper by a friend and colleague of mine in Sweden, Dr. Göran Isaacson, back in the year of 2000, when he first published a study showing that there was a decreased risk of suicide in Sweden among people who were associated with an increased use of antidepressants in the population. Now that study's been replicated a number of times over the years, and that applies to people of all ages and both genders. So
Wow.
it looks like that not only the evidence suggests that there's no increased risk of suicide with antidepressants, but in fact that the risk of suicide in the population goes down with the greater use of antidepressants.
So that's great. What other problems do you see with the black box warning?
Well, there are several. The black box specifically, as I mentioned before, targets young people. And since it started, there have been several studies have shown that prescribing of antidepressants among young people in particular, but maybe in the general population, has decreased. And so while there was this decrease in prescribing of antidepressants, which may have been one of the desired outcomes of the black box warning, or may not have been, there also have been reported, unfortunately, increases in suicides, particularly among young people, in several different countries, including the United States and Canada and Sweden. That the Swedish study, which looked at toxicology, indicated that the young people who were committing suicide, the majority of them, were not being treated for depression. So it wasn't like the ones who were being treated for depression were responsible for the suicides. It was the ones who were not being treated.
Yeah.
And so the information we have in this country that suggests that there's been an effect is that since the black box has gone in effect around 2004, 2005, there has been a steady increase in the number of suicides and rates of suicides in this country back up to levels that they were at before the new antidepressants became available back in the 1990s.
But let's assume, for the sake of the argument, that there has been a negative fallout from the black box warning in terms of antidepressant prescribing. Are there other factors at play?
Yes, there are, and I'll try to be brief as I can with this, but they're important. One thing we know for a long time, and as you, as someone who studies this and reports on this information, know as well as I do, there's always been a compliance problem in terms of treating people with mental health problems, and particularly with depression. It's always been a challenge for physicians. Back in the 1980s, my colleagues and I did a study in San Diego of suicide, and we did extensive toxicology examinations on postmortem following the suicides, looking for drugs and so forth. And what we discovered was that 2/3 of the people who had been prescribed an antidepressant recently prior to their suicide did not have any of it in their system, which meant they may have been prescribed it, but they weren't taking it. More recently, there's been a study from Utah of young people in which there were identified 14 young suicides who had been prescribed antidepressants, and when they were studied for toxicology, none of them had it in them. So that meant none of those 14 adolescents were taking the medicine that they had been prescribed. Isaacson's Swedish data are very similar to that, as I mentioned before, indicating that the rate of detection of antidepressants in young people particularly who were given them is less than 60%. So the question is compliance is a big problem, as we well know.
Yeah. So do you think it would help if the FDA modify the wording of this black box warning?
Well, it's interesting. The FDA actually did modify the warning at one point. There was some concern early on that it didn't balance the picture very well, that it didn't give the impression that there was a danger to depression, that it was a potentially fatal illness, and that doctors should be aware of that. So the FDA modified the statement, indicating that depression was a major contributor to suicide, and in the black box, and that should be also taken into consideration. Unfortunately, as we can see, there hasn't been any apparent change in the trends that I've already talked about in terms of prescribing or suicide rates. Now, this situation was reviewed by Professor Richard Friedman from the Cornell Wild Medical Center in New York for the New England Journal of Medicine back in 2014. And he argued at that point for the removal of the warning. And after I saw that and read that and jibed with what I knew about the data, I certainly would concur with his recommendation.
But does the FDA ever remove any black box warning on medications?
Yes, they have, as a matter of fact. In fact, recently they removed they approved removal of the black box from a medication called varenicline. I don't know if you're familiar with it, but the brand name is Chantix.
It's for smoking cessation.
Right, for Chantix, for smoking cessation. And you may have remembered seeing the ads from, a year or so ago that they warned about, the suicidality and all this. But apparently recently, in late 2016, the FDA has approved removal of that block. So it can be done, I suppose.
How did they do that for that particular medication for Chantix?
How did they arrange to have it done?
Yeah.
I don't know. I could think of two possible mechanisms. One would be that the pharmaceutical company, continued to gather information and data and so forth, and provided them with enough information that it changed their minds. Also, and as this is purely speculation on my part, but I'm going to allow myself to do it. Smoking is a different kettle of fish than depression. Everybody knows that smoking is no good, and so from a variety of standpoints. Anything that shows promise for dealing with this really very serious health problem around the world, but and maybe not so much in this country anymore, but certainly it is. Might be viewed differently than something as not quite as easy to get a handle on as depression. Depression has some difficulties in terms of definition and so forth that may make it a little more difficult for the drug companies to make a point about. Of course, the drug companies also have to operate under this vested interest problem. There is I think some level of concern maybe in this country by many people that the pharmaceutical companies have too much influence over what's going on, and that they might not be trustworthy in a sense. And given the problems that the FDA has had in the past, as I mentioned with the Vioxx thing and so forth, I couldn't blame them for wanting to err on the side of conservatism, and maybe would not be as amenable to the drug companies as if they petitioned to have the black box removed. What I think is probably would be the method of getting something done would be for the many professional organizations, citizens groups in this country who deal with mental health problems, and many of them because you've interviewed lots of them, as well as two national organizations. There's American Foundation for Suicide Prevention and American Association of Suicidology, which both foster research and study of suicide. And it would seem to me that if those people could somehow be brought together from the scientific and public community to influence the FDA, they might be willing to reconsider it. But as far as I know at this point, they're not doing so.
Mm-hmm. Do you think the FDA is being overtly cautious on this issue?
Well, they have a huge job to do, and I don't have to preach to you about it, but because you understand this. I mean, they are under the gun from providers of both medications as well as devices that are used medically to get them approved, but under the gun from not only physicians but the consumers as well as the producers of these items, to get them available to the public as quickly as is reasonably and safely possible. So a good deal of their time is rightfully taken dealing with new products. As I mentioned before, if I were in charge of that operation, I would certainly want to err on the side of being conservative as well, being cautious. And so I'm a little hesitant to be too critical of their stance on it, except that I think in this particular case, there is now enough evidence put together, and as I mentioned, I agree with Dr. Friedman, that it certainly ought to be, I think it ought to be brought up for reconsideration, and if I had a vote, I would vote to do away with the black box.
And what do you think a provider can do when it comes to prescribing antidepressants?
I think providers need to keep two things in mind. One is that the black box itself does not prohibit, as I mentioned earlier, does not prohibit them from prescribing the medication if they think it's indicated. And they need to be aware, they need to continually be aware of what the risk of suicide is among people with depression, and balance that out, obviously. But I think that I think providers have in general become more cautious and less willing to prescribe medication than they were before the black box came out. And I think there needs to be more education of them about the importance of not erring too far on the side of caution that way, because we're talking about lives at risk, and without any evidence that the antidepressants actually do cause people to commit suicide, I think the pendulum should swing back a bit, and people should start getting more aggressive again about treating depression with medication.
Yeah, maybe also close monitoring with the patients. After starting an antidepressant, come back earlier or check with them over the phone to see how they're doing.
Yeah. So you're right. That's absolutely. I think. Yeah. The compliance issue is extraordinarily important. There have been many studies that have shown that the greatest risk for suicide among depressed people is shortly after they begin treatment. And of course, at one point, I always thought that maybe it was the treatment that was causing them to do it. But in reality, that's not what happens. What happens is people wait until they are very sick before they go to the doctor. Right. And so they are more likely to be, on the verge of having something bad happen. And if they don't take their treatment at that point in time, the risk of that happening is even greater. So early follow-up and monitoring compliance are extremely important.
Another issue is on the treatment of depression. It's not just medication. Yes,
that's true. I mean, there are a number of studies that I think are well accepted. For example, that in a general population of people who report to someone about being depressed, the use of various psychotherapeutic techniques, for example, may be effective in relieving their depression. And so the question comes up, well, if that's the case, then why not avoid the whole argument about the black box and just do away with medications altogether and stick to non-medical treatment of depression? And I think there's a difficult definitional issue to deal with before you make that conclusion, and it has to do with the diagnosis of depression. There is a condition or syndrome or group of symptoms that we know of as depressive illness or what do they call it now, major depressive, whatever. I forget what the terms are now, but you know what I'm talking about. and then I'm a little behind that curve, but it's still the same. I think it's still call it major depression and bipolar disorder and things like that. So But the question is, does everybody who meets those criteria, is everybody who has unhappiness for some reason fall into that category? And so you have a distinction between.
I would hope the clinician would know how to differentiate those. And
well, it's not easy. It's not always easy to make that distinction because, and at least in my experience, I see people who I was absolutely convinced, for example, were being made very unhappy by their work situation.
Yeah.
And the right approach to it would be for them to, deal with that through counseling or therapy or something, rather than taking some medication. But they were extremely unhappy. And it was very difficult to tell. And a lot of those people actually would come to me and say, well, I want some medication for this. And I would think in my mind, well, I could do that, but it's not really going to change the situation much. And then there are other people who you see who come and they tell you the story about their depression, and it absolutely sounds like the diagnosis of major depression and so forth, and it's not related to any specific situation. It's over, and you say to them, well, I really think this medication was going to help relieve your symptoms and make you feel a whole lot better about things in general. And they would say, well, I really don't. What I really need to do is to talk to somebody about this, and so it gets to be a problem in the clinical arena. On the one hand, the clinician being able to distinguish between the two, but also getting the customer, the client, or the patient to accept your opinion about it and do it. Yeah. So it's not an easy way to go.
Yeah, it's not, because I'm just imagining myself in primary medicine, and that's the time that you have with the patient, 15 minutes.
Well, that's dependent on the practice style of whoever is doing it. Unfortunately, I think there has been a presentation of that distinction, that the physicians are time dependent on their billing and so forth and so on, and they must see a certain number of people to make whatever income they think they need to make. I on the other hand was fortunate in that, being in an academic setting, never really had to earn a living doing what I did, at least practicing. So I saw patients, but I never had any time constraints on how long I spent with them, which was satisfying to me, but I'm not sure it would have done well. So you do indeed see this kind of this distinction between the physician who may have short periods of time to deal with medication decisions and may not be able to take into account the whole picture, versus non-physician therapists who can spend time with people, but they can't do the other side of it. So you see a lot of people getting together like that. And I know you did a piece recently about integrated treatment and so forth and so on. And those kinds of settings can be good if people are working together well in those settings. So you can get both, best of both worlds in those cases. And I think my recommendations more often than not were, I think this medication may help you, and it very well may help you a lot, but that shouldn't stop you from getting counseling or therapy if you think you need help with other problems. And I can refer you to somebody else who does that probably better than I do for that. And a lot of people would opt for that. Some wouldn't. They would, they just didn't want to do that. And some people didn't want to take the medication, like I said. So you have to be flexible about it. But I think offering both sides of treatment like that is the best clinical practice.
Right. Dr. Rich, do you have any final thoughts?
Well, my only final thought is that, as I mentioned, is I think the time has come for the public to somehow become aware of this on a greater scale, and I think it's up to us as the professionals to make that effort to the public, because certainly, the pharmaceutical companies are going to be hesitant to do it because they still got the black box on them and so forth. And I think it's going to take more consumers and more providers just coming forward and trying to put pressure on the FDA to reconsider their position and do it probably through their professional and citizen associations that deal with these things.
Okay, great. Thank you so much for answering my questions and educating us about the black box warning on antidepressant and how it has impacted the way we deliver mental health care. So, to those who are watching, thank you so much. Come back for our next episode as we explore the question, what does it mean to deliver world-class mental health care? Thank you, Dr. Rich.
Thank you, Ryuj.